Hi, my name is Dr. Shahid Ahmed, and I'm one of the genitourinary medical oncologists at University of Vermont. I'm also an assistant professor of medicine, and it's my privilege today to talk about harnessing the immune system to fight cancer. I don't have any disclosures. I do have some slides that I have borrowed from some of the conferences that I've attended. So today we will be talking about a brief history of immunotherapy, where it came from and where it's going. We'll talk about the role of the immune system in cancer, even before it's detected, the role of the immune system in finding and getting rid of cancer. And then we'll talk about using immunotherapy to treat cancers. We'll also discuss the role of diet, how bacteria can affect all of this, the role of antibiotics, probiotics, and different vitamins that could potentially impact the use of immunotherapy. And then finally, we'll talk about what's the cutting edge stuff happening and what does the future hold for immunotherapies. So it all started from Dr. William Coley, who was very upset because his first patient who had sarcoma died. And he saw that people who got infection of some sort and were septic actually had a nice response to the tumor, and the tumors would start shrinking. So he thought that maybe I can make a soup of bacteria and inject that into tumors, and let's see what happens. So he injected this back in the late 1800s, a soup of strep pyogenes and streptomycins, and injected this into his patient with sarcoma on the leg. And lo and behold, the tumor shrank down. And he didn't know what was really causing that, but was very intrigued, and then went on to do a clinical trial where he subjected about 100 patients or so to this. And he published his results, but his colleagues were very skeptical about this mysterious Coley soup. However, this early kind of data that bacteria can somehow cause cancers to shrink was then taken upon by other scientists, including Dr. Paul Ehrlich, who developed the theory that there is actually immunosurveillance that is going on at all times in our body that is trying to actively get rid of cancers. And then that has kind of developed over the past century into various things. So we'll be talking a little bit about that. Now, we know after all this research of the past 100 years that the immune system has two main arms. There is the frontline warriors, the innate immunity, that whenever you get exposed to something, these are already set to kind of take care of that threat. And then there is the adaptive immunity. That's the part that develops a memory of what it's dealing with, and then so that if you ever get exposed to it again, that you can get a nice response to that. So these are the two arms of the immune system. And in these arms, there are various different kinds of cells. This is just a very simplistic cartoon here of 4 of the main types that are involved in cancer surveillance. But there are a huge number of different subtypes of immune cells. Essentially, you have the natural killer cells that get rid of bacteria and cancer cells. You have the cytotoxic killer cells that poison cancer cells. And then there are the memory cells that after those cells have died, the immune system goes there and picks up their remains and actually learns from it and creates a memory of that. And essentially, thereby, if ever the cancer or that bacteria is exposed again, that the immune system has a memory of it and can go back and do that, do what it's supposed to do. And finally, there are a few cells called suppressor T cells, which have the function of calming down the immune system after the immune system becomes too active. And this has a role to play in our body to prevent autoimmune problems where your own immune system might be attacking your organs. However, cancer cells are sneaky, and they can learn to use these cells to actually slow down the immune system so that the cancer cells can grow. So during a normal cell cycle of, or the normal cycle of immunity in the body, what happens is that, let's suppose if you did have a cancer cell and would eventually live its normal life and then die, that the immune system comes over there and picks up its remains, takes it to the lymph node here. And then the lymph node is where these immune cells, they present all of this stuff that they've learned from this site of cancer death and expose the other immune cells to that area. This is where memory cells live. This is also where T cells live, that once they get exposed to this, they increase the number of T cells that are going to be fighting against that thing. And then they go all the way back to that initial site where they found the cancer, just to get rid of any other cancers. And as you can see, once the immune cells kill those cancer cells, there's more of this phenomenon going. So it's a cycle here where the immune system has a way of keeping on to deal with any threats that may arise. And even when cancer cells are trying to change over time, that the immune system has a way of doing this. However, there are a lot of molecules at the surface of these T cells that essentially guide them into what to attack and what not to attack. So there are these stimulatory molecules that tell the T cell to attack, whereas there are also these inhibitory signals that tell the T cell not to attack the cancer cell. And these inhibitory signals are what is used by cancer cells to actually evade the T cell. So if a cancer cell was expressing a molecule that would then interact with this inhibitory signal, well, then the T cell will just sit on the side and not really do any harm to the cancer cell. And this is the subject of the new studies and the new drugs that have come about, is essentially getting rid of some of these inhibitory signals. And that way your T cell can keep on doing what it's supposed to do. So essentially, the first step in the growth of cancer is that the first time a cancer cell is formed, typically the immune system is able to take care of it. However, over time, there is some genetic instability in the cancer cells, and that leads to all the cancer cells that are susceptible to die, but a few that become resistant to the immune system. And eventually these resistant cells start to grow. And they grow because they've kind of put an invisibility cloak on themselves. They have a way of hiding from the immune system, and that's why they do grow. And that's why we diagnose cancer, usually at this stage, once the cancer has learned to evade the immune system. So these invisibility cloaks that the cancer knows how to put on have been the target of recent advancements in oncology, and we have developed drugs that target these invisibility cloaks. So your own immune system can now detect the cancer again and fight it. And the two people responsible for discovering these molecules, received the Nobel Prize. So Dr. James Allison from Texas and Dr. Dasuko Honjo from Tokyo. They both got the Nobel Prize in 2018 for this. So now let's talk a little bit about what other kinds of immunotherapies exist and what is the current state right now. So essentially, we have the immune checkpoint inhibitors that I just spoke about. These are the drugs that target those inhibitory molecules. We also have vaccines that can potentiate the immune response. We also have some new virus therapies that can actually cause some cancer cell death. And most recently, we've now been kind of going into adoptive cell therapy, and I'll explain what that means. So this is the first kind of treatments that we talked about. These are also the most commonly used drugs right now. There is a molecule that the T cell, when it's interacting with other immune cells, uses, and we have a drug that targets that. It's called ipilimumab. And then we also have a target for these molecular interaction between a cancer cell and the immune cell. And an example of that drug is nivolumab. What is most interesting is some of the vaccines that we have. Traditionally, there were a lot of trials with vaccines for over, a few decades actually, but they were all not really helpful for one reason or another. And the biggest reason I think in that is that the vaccines typically only have a part of the cancer in it and not the entirety of different molecules in the cancer. And so if you're just kind of arming the immune system to target one antigen, then it might not be as effective. But if you target multiple antigens, maybe it might be more effective in that scenario. So this vaccine, this is the first vaccine that is approved in cancer, in prostate cancer cells. Here, what we do is we take the patient's white blood cells, we harvest them, and then we expose it to this protein that is found in prostate cancer cells called prostatic acid phosphatase. So once we show the immune cells of the patient the protein that is expressed by the cancer cells, then we also kind of give this drug that boosts those white cells and helps them make a lot more of those cells. And then you've essentially expanded the number of white cells. So if you took, as a hypothetical figure, if you took 10 cells, this drug will make it into 100. And once you've kind of had now an expansion of that army, you infuse it back into the patient. And those T cells, now that they have learned about this protein that the cancer expresses, they can go back in and do a better job of fighting cancer. So with this drug in particular, we have seen now that people live longer with prostate cancer, and it is now approved. This is an example of an oncolytic virus. So TVAC is a drug used in melanoma, where we have a virus that is very similar to the herpes virus. However, we have kind of removed its virility, where it can infect humans and cause issues there. So we've kind of genetically engineered that out of the virus. But the virus has properties to kill cancer cells. And so we typically inject this into the tumors themselves, and cancer cells die. The idea here is that when cancer cells die, that you're kind of increasing that cancer immunity cycle again, because cell death will then lead to the immune cells coming there, picking up the debris, taking it to the lymph node again, and exposing the rest of the immune system to the cancer cell, and then increasing its effectiveness. What we've seen with TVAC is that sometimes when we inject it into one tumor, that tumors in other places that have not been injected also start shrinking down, which is evidence to the fact that the immune system starts to recognize the cancer better, even in places where you've not injected it. So this is a very useful treatment that we use in melanoma, and there are a lot of trials with oncolytic viruses happening currently in other cancers as well. CAR T cells are also a very novel treatment that has been there now for a few years, and it's very expensive and it's a big process, but the idea is very novel. What you're doing essentially here is that you're taking the white cells from the patient, and then you genetically engineer those white cells. So you introduce a viral vector that goes and becomes a part of the T cell's genome. And then once it's part of the genome, the genome is what tells the T cells to do what they do. And the virus already has the information regarding cancer cells. And so you're essentially, through that virus, passing on information to these T cells. And now these T cells, which are educated, know better about the cancer cell, they express molecules because of their genome being changed. And they express molecules that can detect cancer cells. Then you clone them and put it back into the patient. And we're seeing some really excellent results with some of these treatments. Right now, there are a few cancers for which this treatment is even approved by the FDA. And then there's a lot of other clinical trials that are happening in this setting. So this is called CAR T cells, and seems like there's a lot of advancement happening in this realm. We're also now more recently doing what's called TILs, or tumor infiltrating lymphocytes. Essentially, what you do is you take a patient's tumor sample, you remove it. Once you've removed it, there are always some immune cells that detected the cancer and are inside the tumor cells, mixed with the tumor itself. Those are the immune cells that had the ability to recognize the cancer, but then for some reason, are just sitting there, not actually killing the cancer cell. One of the reasons might be that there's that invisibility cloak that's stopping it. And then there's a lot of other reasons that also could happen. So you're essentially taking this part of the immune system that already knows about the cancer, but just is not very effective or does not have the resources to actually deal with the cancer. So you take these immune cells and you clone them, and so you give them robustness by making many of them, and then you infuse it back into the patient. And this treatment was just recently, shown to have a tremendous effect in melanoma patients, and is currently being explored in other cancers as well. We also are now seeing more and more BiTE molecules. BiTE molecules are essentially these drugs that have two arms. One arm attaches to the immune cell, and the other arm attaches to the cancer cell. And it essentially brings the immune cell and the cancer cell in close vicinity of each other so that the immune cell can get rid of the T cell. So we have a few examples of these drugs, such as blinatumomab, that is already approved in this setting, and is used in routine clinical practice. So as you can imagine, there's a lot of research going on. All of these drugs have come about in the past 10 years. So about 2011, that's when the first checkpoint inhibitor, nivolumab, was approved for melanoma. And since then, there has been a litany of clinical trials that has happened. And once we knew that this could work for melanoma, we've been kind of doing these drugs for other cancers in clinical trials. And since then, there have been a lot of FDA approvals, multiple different cancers. In fact, there are, especially with those checkpoint inhibitors, those have the most wide-ranging approvals to date at this point, because they've been in the market longer. But very exciting. This has kind of changed how we practice oncology. Over 10 years ago, mostly what we had were maybe some pills or chemotherapy, and they would work for some time and then would stop working. However, the benefit of immune therapy is that once you boost the immune system, and if it does a good job at doing it, well, then there is a possibility that the immune system can develop memory of the cancer again. And thereby, essentially, you could have a response to the treatments for a very long time, because the immune system will keep on doing its thing. Even when the cancer is trying to change, the immune cells can keep on doing. So it doesn't work for everybody, but when it works, it can sometimes have miraculous results. So much so that this is the first time in history that we're seeing some patients with stage 4 cancer, stage 4 melanoma, for example, gone to the brain, the lungs, the liver, and they got exposed to those drugs. And, it's been 5 years, 10 years already, and those patients are still alive. And we don't know how long they're going to be alive because the drugs are only 10 years old. So whether there is a cure for stage 4 cancer or not, we know that we've not had a cure for stage 4 cancer typically. But we might be looking at something like that in a minority of patients who get these drugs. However, the idea is that hopefully with time, we're going to be able to get that benefit to a lot more patients. So what are the side effects of these treatments? When you're boosting the immune system to go fight the cancer, sometimes the immune system can attack your own organs. And that's where all the side effects come from. So there's no chemotherapy type of side effects like nausea, vomiting, hair loss. Those kind of things typically don't happen with immunotherapy. But what you get is sometimes the immune system can attack your own organs. So because the immune system lives everywhere in the body, it can attack pretty much any organ it likes. So we've seen the immune system attacking the lungs, the colon, the brain, the heart, and what we've seen most commonly, though, if you're getting, for example, just a one checkpoint inhibitor, the rate of side effects is pretty low. So typically people will have no side effects, or maybe a little bit of a rash or some hypothyroidism that we can easily deal with. I would say almost 90% of people don't have serious side effects, but about 10% of people will have a serious side effect for which we have to stop the treatments. And so that's with a single checkpoint inhibitor, but if you use two of them together, well, the side effects go up to about 30% or even higher sometimes. And with some of the other treatments that we talked about, like the CAR T cell therapy, the side effects are, the percentages are in the 80% and 90%. But the good thing is that we know how to deal with these side effects now because these drugs have been around for quite some time. And more often than not, they are reversible and get better with time. So now let's talk about what else affects the immune system. How else can we bring the benefit of immunotherapy to everybody and not just the few people who have tremendous benefit from it? So one of the things that we have realized is that the microbiome plays a huge role in how immune system works. Microbiome is essentially all the bacteria in your body. The gut has a large reservoir of bacteria, and the gut microbiome has been the one that's studied the most. And we've seen that the gut microbiome can both lead to cancers, but also protect you from cancers. It can also improve the effectiveness of treatments once you have developed cancer. And the reasons are manifold. We're still trying to understand it, but essentially, what we think is that these bacteria that live in the gut, they interact with the immune cells that live in the bowels. And you can imagine that the immune system, most of the immune system will be living on the skin, in the lungs, and in the gut, because those are the places that are exposed to things from outside. So you have a lot of immune cells in the gut, and you have a lot of bacteria. And essentially, these bacteria, most of them are beneficial bacteria, and they provide a training ground for these immune cells. So that they, if you have a diverse microbiome, you have a lot of different kinds of bacteria, well, then your immune cells will be exposed to a lot of different kinds of bacteria. And essentially, there's going to be a lot of diversity of the immune cells. Well, if you have a diverse immune system, it's going to be much easier for a diverse immune system that's already been exposed to a lot of things to be able to recognize cancer and take care of it. So, there's an association that we've seen now between cancers and the gut microbiome. And what we found is that there are certain bacteria that are enriched in certain cancers and others that are enriched in people who don't have cancer. There's also bacteria that are enriched in people who respond to immunotherapies, whereas those who don't respond to immunotherapy, they have certain other kinds of bacteria. So we're learning how, there's millions of types of bacteria in the gut, and we're still kind of trying to understand by doing these early studies right now how these interact. So, if you take recently, what's most interesting is that they took the microbiome, the gut bacteria of somebody who responded to immunotherapy, and gave it and did a fecal transplant essentially, and gave that microbiome to another person who did not where the immunotherapy was not working. And lo and behold, the immunotherapy starts working at that point in time. So there is a lot underneath the surface here with the gut microbiome that we still don't understand. It's based initially on mice data where they tried this experiment in mice and showed that it was effective. And so now the first in human studies have happened after that. Now, how can we change the gut microbiome? How can we make it in a way that it can benefit us? And there are a lot of factors. There are some factors that you can change and others you cannot. For example, you can't change your age or your sex or your genetics. And these things do also play a role with the microbiome. And the microbiome changes with age. It also is different for males and females. But then there are these other external factors that we can affect: diet, medications, your weight, and psychological factors, and where you live might actually also play a part. So an example of this is a study where they gave African people an American diet and then African Americans an African diet. So they swapped the diets of people living in two different continents. And within a couple of weeks, they were able to see that the microbiome swapped completely, that the bacteria that were found in African Americans were now being discovered in Africans and vice versa. And so diet has a huge role to play in the microbiome. We know now that bacteria kind of exist almost everywhere in the body. In fact, we think that there are more bacteria on our body or inside our body than there are normal cells. We've now discovered bacteria in breast tissue, in arteries with plaques, in bladder cancer and lung cancer specimens. And there's even a recent report that there are bacteria in the brain too. So these are normal bacteria that live peacefully, but are affecting the immune system somehow. There is also studies that have shown that certain bacteria, if you have these few bacteria in pancreatic cancer patients, that they end up being, that their survival is more compared to other people who don't have these bacteria. So certainly it goes both ways. The microbiome could both help, but also could hurt as well. There's data now that shows that antibiotics can make things worse if you have cancer and if you're on immunotherapy. The idea is that antibiotics get rid of a lot of the microbiome. They kill these helpful bacteria. And so when you're getting rid of bacteria, your immune cells are not able to do as good of a job as they were doing before. And so we have noticed that people who get antibiotics, they have a decreased overall survival. And for them, melanoma comes back more so than people who've not received antibiotics. We've also seen that antibiotics could potentially cause more side effects from the immune system. Again, if you can imagine, if you don't have those bacteria to guide the immune cells, well, then the immune cells could potentially start causing autoimmune problems where it's attacking its own organs instead of fighting the cancer. So antibiotics can be harmful. Vitamin D might have a good role to play, both in preventing side effects and also increasing the effectiveness of immunotherapy. So in summary, we know that, regarding antibiotics, for example, sometimes you need it because you have an infection and, if you don't treat the infection, you could have very adverse outcomes. But using antibiotics prudently and only when necessary, especially when you're on immunotherapy, is important. We think that we should avoid probiotics because probiotics can actually cause a certain type of bacteria that you're introducing to the system to dominate over your natural microbiome. And so we think probiotics could potentially reduce the diversity of the microbiome. Other than that, a diet that's rich in vegetables, fruits, and beans especially has been shown to increase your diversity of your microbiome. And the more diverse your microbiome, the better it is able to help your immune system. So now finally, we should talk a little bit about the future of immuno-oncology and where we're headed. These are all the approvals that I was talking about. I think the last one here is till 2019. We've not updated the slide, but till 2019, see all of these cancers with all these drugs that have been approved, with all immunotherapy drugs. And there's been a lot more after that. However, the immunotherapy doesn't work in everyone, and it benefits a lot of people, but then it doesn't work at all for some people. And for some, it works for a little bit and then stops working. So one example of this is bladder cancer, for example. And in bladder cancer, only 20% of people, 20 to 30% of people respond to immunotherapy. So the question is, how can we get that benefit to other people? For that, we first have to understand why does immunotherapy not work for a lot of these people? Well, one reason, and there are several reasons, because we talked about the cancer immunity cycle. There could be hindrances at multiple steps of this that could be leading to an immune response that's not as robust as you want it to be. Sometimes your immune cells are not able to express these antigens to other immune cells. Sometimes you don't develop memory cells. Sometimes the cancer cells keep hiding from the immune system. And so we're now learning all these new mechanisms by which the cancer can evade the immune system and trying to develop treatments for it. We know that certain cancers are less likely to be targeted by immunotherapy. For example, pancreatic cancer is a cancer where when we take a sample of it, we actually, in the tumor, we don't find any immune cells at all. We call it the immune desert because the immune system has just totally failed in being able to recognize those cancer cells. There are then other examples of immune excluded tumors where the immune cells are there here on the edge, but they're not able to get in. They're just kind of sitting there and they're not able to do their job. And then in certain cancers like melanoma and kidney cancer, we see that the immune cells do a fantastic job at finding the cancer, and those immune cells already are in there in the cancer taking care of things. So our treatments work better for people who already have a pre-existing immunity against the cancer, but works less and less for those with an immune desert. So that's where all the treatments are being developed right now, is trying to get more and more immune cells to recognize the cancer. And there are, just in the past year or so, there have been newer things that have been approved. I've just given here 3 of the most important ones that I think are important. There's the tumor infiltrating lymphocytes. We talked a little bit about there, where you remove the tumor itself, extract the immune cells that recognize the cancer, clone them, give it back to the patient. Then there are newer invisibility cloaks that we found called checkpoints. And we have a drug for the third checkpoint inhibitor called the LAG3. So we have a LAG3 inhibitor now. And we have some fusion proteins. Fusion proteins are essentially kind of similar to the BITE molecules we talked about, but they have a way of arming the immune system and making it easy for the immune system to recognize the cancer. Whenever possible, I think it is important to be a part of a clinical trial, especially if you have a diagnosis of cancer. The reason being that, a lot of these treatments have become available because people went on clinical trials. And at that time, for that patient, there wasn't any other drug and they may not have survived. But because they went on a clinical trial, they gave themselves a chance, and some of them are still alive. So I think giving yourself the best cutting edge technology and the best chance of getting those treatments and being exposed to them is often through a clinical trial. But also it helps us understand the cancer better and hopefully, continue this fight against cancer. A lot of the trials now, they're trying to combine different immunotherapies with other drugs or with other immunotherapy drugs to increase the effectiveness of immunotherapy. We're trying to bypass the resistance that develops to immunotherapy. And then we're now bringing immunotherapy earlier in the course of the disease. Whenever studies are done, they typically happen first in stage 4 cancer patients because those are the ones who need those treatments the most. But over time, once we show that this drug is effective in that cancer, we do more and more trials in the earlier stage setting. And so now there are a lot of trials in the stage 2 and 3 setting for a lot of cancers where immunotherapy has been used. So if you look at the first 2 curves here, that was how how it used to be. If you were not to do any treatments, you had a limited survival. If you tried the chemotherapy, maybe you could live a little longer, but the cancer would still cause you to die. Whereas with immunotherapy, yes, still a lot of people die. It doesn't work for everyone, but there are a few people for which it works, and sometimes it works for a long, long time. An example of that is Jimmy Carter, who at 92 had stage 4 melanoma that had gone to the brain. And he's still alive at 96 after he got pembrolizumab. That's a testament to that fact. That's certainly unheard of prior to the immunotherapy era. And now the studies are trying to improve this benefit for patients so that it's not just a few who get the benefit, but a larger majority of people hopefully will be able to derive that benefit. And we have a lot of different molecules that we can target or we are thinking about or studying, and there are newer and newer treatments that are becoming available. And eventually the idea is that we're able to detect the cancer better, we're able to detect these molecules better, we're able to modify the microbiome, and then be able to kind of figure out who are the patients for whom the immunotherapy is going to work and who are those that are where it's not going to work, and how do we increase the chance of them working. So with that, thank you so much for attending this talk, and I look forward to your questions. Thank you.